Imagine going in for, a quick outpatient medical procedure to fix a really frustrating daily problem. We're talking about leaking urine basically every time you laugh or cough or, I don't know, try to squeeze in a workout.
Right, something that totally disrupts your day.
Exactly. And you're told, hey, this is a simple, minimally invasive fix. But then a month later, the swelling goes down and, well, you're still leaking.
Yeah, which is incredibly frustrating.
Right. So did the doctor fail? Is your body, somehow rejecting the treatment? Or is there this hidden two-step medical secret that no one actually bothered to tell you about in the consultation room?
It's just such a jarring position to be in, honestly. You go in expecting this binary outcome, right? Like broken or fixed.
Yeah.
And instead, you just find yourself wandering through this weird diagnostic gray area, wondering if you need to, escalate to major surgery just to get your life back.
And untangling that gray area is exactly what we are doing today. So welcome to this deep dive. We've pulled together this massive stack of medical sources for you. I mean, we're talking the 2025 American Urological Association guidelines, comprehensive clinical trial data, systematic reviews, and even actual post-procedure patient leaflets.
It's a lot of material, yeah.
It is. But we are doing all this to answer one very specific, very critical question for you, which is, what is the success rate of repeating a periurethral bulking procedure if mild leaking actually persists?
And, that might sound like a super niche question at first glance, but if you or, someone you care about is navigating this landscape, I mean, it is the absolute center of the universe.
Absolutely. So here's our roadmap for today. First, we have to establish a baseline, like what even is urethral bulking and why do its effects sometimes just fade away?
Right, we have to start there.
Yeah, and then we'll look at the reality of going back for round two, really digging into the hard numbers on reinjection. After that, we'll get into the specific biology that determines who actually benefits from a repeat injection.
And who absolutely does not, which is just as important.
Exactly. And finally, we're going to uncover this counterintuitive medical paradox about surgical side effects that feels completely backward, but actually makes perfect biological sense.
I love that part. The overarching theme here really challenges our basic assumptions about how a medical fix is even applied.
Because we're so conditioned to expect that one-and-done cure.
Right, exactly.
Yeah.
We want the magic bullet.
Right. So let's just start right there at the baseline. The condition we're looking at is stress urinary incontinence, or SUI. And I really want to be clear for anyone listening, this isn't that sudden, overwhelming urge to go to the bathroom.
No, that's overactive bladder, totally different mechanism.
Right. SUI is physical. It's the physical leaking of urine under pressure.
And that distinction is so vital. I mean, the literature notes that SUI affects up to 25% of women, which significantly disrupts daily life. And the root cause usually involves two overlapping physical issues.
Okay, lay them out for me.
So first, you have weakened pelvic floor muscles that just cannot adequately support the bladder during moments of physical stress, like that laugh or sneeze we talked about.
Right.
And second, there's often this thing called intrinsic sphincter deficiency, or ISD. Basically, this means the actual muscle valve surrounding the urethra has lost its tone. It's simply too weak to stay completely closed when your intra-abdominal pressure spikes.
Okay, so if you want to fix this without resorting to, a major invasive surgery, I mean, installing a mid-urethral sling, which is intense, doctors offer urethral bulking.
Yeah, exactly.
And the sources describe this as injecting a non-degradable material directly into the tissues surrounding the urethra. They use things like microplastique, which is a silicone elastomer, or Bulkamid, which is this polyacrylamide hydrogel.
Right, but the goal here isn't to glue the urethra shut.
Well, obviously, because the patient still needs to be able to urinate normally.
Right, exactly. The mechanism is literally just about adding bulk to the walls of the urethra to improve that resting seal.
Okay, so I picture it sort of like weather stripping a drafty door.
Oh, I like that.
Right, you aren't nailing the door shut. You're just adding enough soft, bulky material around the inner frame so that when the door shakes in the wind, air doesn't leak through.
Yeah.
You still need the door to open smoothly when you use the handle, but you want that seal tight when it's closed.
The weather stripping idea is a really good starting point, but, let's add a bit more biological reality to it. Unlike a stiff wooden door, the urethra is a dynamic, living tube.
Right, it's organic tissue.
Exactly. And initially, this biological weather stripping is highly effective. The clinical data shows that 60% to 70% of women notice a cure or a really significant improvement right off the bat.
Wow, that's pretty high.
It is. The procedure is fast, it's outpatient, and those immediate numbers look great.
But, and here's the catch, the data also shows a big drop-off. The British Association of Urological Surgeons, for example, they note that long-term success hovers around only 50%.
Right.
So if you put the weather stripping in, why does the draft come back?
Well, it comes down to a few physiological variables, and it's heavily dependent on the specific agent they used.
Okay.
So with older particulate-based agents, the carrier gels that actually transport the solid particles into the tissue, those can actually be absorbed by the body over time.
Oh, so the body just sort of eats the gel.
Basically, yeah. And when that gel vanishes, the total volume of the bulk obviously decreases.
That makes sense.
Now, newer hydrogels like Bulkamid, they're designed to resist that degradation, so they maintain their volume for years. But
Yeah.
even then, the material can migrate slightly through the loose connective tissue over time.
It just shifts around.
Exactly. And perhaps most importantly, the underlying condition hasn't actually been cured. The patient's native pelvic floor muscles might just continue to weaken, eventually overriding whatever bulk was added in the first place.
So that scenario perfectly explains why someone ends up back in the doctor's office,
Yeah.
right? You get the procedure, you feel great, and then like a month or two later, you're experiencing this mild, persistent leaking again.
Yeah, exactly.
And the doctor looks at you and suggests a top-off, a second injection.
Yes. And when we dive into the systematic reviews on these top-offs, the variance in reinjection rates is just staggering.
What are we talking about here?
Across different clinical studies, hospitals, and specific agents, the rate of patients getting a second injection ranges from a low of 8.3% up to a massive 77.3%.
Wait, 77.3%. That is wildly broad spectrum.
It really is.
But let's zero in on Bulkamid for a second because it comes up so frequently in the newer data. Our sources state that roughly 43% of patients require a second injection within just 1 to 2 months for optimal results.
Right.
And generally, 44% of women will ultimately request a reinjection at some point.
Yeah.
I mean, the 2025 up-to-date review even spells it out, noting that these procedures routinely require additional injections to reach maximum efficacy.
Yeah, the literature treats this as a totally standard feature of the treatment landscape, not some kind of anomaly.
Okay, but I have to push back here.
Okay, go for it.
If I'm sitting in that clinic and I hear that almost half the patients need a redo in 2 months, my immediate thought is that the first shot failed.
Yeah. Yeah.
Like, are doctors just missing the mark on the first try? Because this really sounds like we're being sold a one-and-done solution when the medical reality is clearly a two-step process.
I totally see why you'd think that, but calling it a failure fundamentally misreads the medical strategy. What's fascinating here is that it's actually a built-in safety mechanism.
A safety mechanism, how so?
Well, if we look at the broader context of urology, the single most dangerous complication a doctor wants to avoid here is overbulking.
Okay.
If they inject too much material during that first session, they can create a permanent mechanical blockage. The urethra swells up, the material takes up way too much space, and the patient goes into acute urinary retention.
Meaning they literally cannot pee at all.
At all. And that elevates a minor outpatient procedure into a full-blown medical emergency that requires a catheter.
Oh, wow. Yeah, you definitely want to avoid that.
Exactly. So to ensure that none happens, doctors take a highly conservative approach on the first try. They purposely undercorrect.
Ah, I see.
The goal of injection number 1 is just to establish a safe baseline. Injection number 2 isn't a do-over, It's a calibrated adjustment based on exactly how your specific tissue accommodated that first dose.
Ah, okay, that reframes it completely.
Yeah.
It's like having a suit tailored.
Oh, yeah, exactly.
A good tailor is never going to hack off 3 inches of fabric on the first fitting. They'll leave a little extra, see how it drapes on your shoulders when you move around, and then take it in a little more on the second fitting.
Right, because if they cut too much the first time, the suit is in the trash.
Exactly. That captures the clinical mindset perfectly then. The first injection is the primary fitting, and the top-off is the final tailoring to get the perfect seal.
You nailed it.
So we know the doctors purposely leave room for a second shot. But does that second shot actually get the job done, or are we just throwing good money after bad here? Like, what is the actual success rate of going back for round 2 if you have that mild, persistent leaking?
The data strongly advocates for the second round. There's this one systematic review and meta-analysis focusing on macroplastique, and it revealed a highly compelling data point.
Lay on me.
It showed that higher study reinjection rates were actually statistically associated with improved long-term SUI outcomes.
Wait, let me make sure I'm not misinterpreting that. You're saying the studies where doctors gave more second injections were the exact same studies that yielded the best long-term results for the patients.
Exactly. It basically proved that achieving that perfect customized bulk usually requires that second calibrated touch.
Wow.
And because of data like this, the standard clinical protocol now dictates that if a patient reports mild leaking at their post-procedural follow-up, which is usually a month or two out, a second injection is strongly recommended so they can, quote, benefit fully.
Meaning, for you listening, if you are experiencing mild leaking after round 1, the odds are heavily in your favor for round 2. You are essentially just completing the original prescription. It's not a step backward at all.
It really isn't.
But wait, if this second top-off injection is basically a required step for success, why do patient information leaflets, like the ones from Wilmington Health or University Hospitals Plymouth, why do they strictly cut it off at 2 attempts?
That's a good point.
Like, why not 3 or 4 top-offs? I would assume, because if you've added weather stripping twice and the door is still rattling, the problem isn't the weather stripping. The door frame itself is broken.
You're exactly on the right track. The clinical guidelines draw a really firm boundary there. If there is zero improvement after 2 sessions, adding more bulk will not solve the anatomical deficit.
It's just not going to work.
Right. So the guidelines suggest pivoting to alternative treatments, whether that means stepping up to a surgical sling procedure or maybe stepping back into really intensive pelvic floor physical therapy.
Which brings up a really important question. If the 2-shot method works broadly, but there's a hard limit where doctors literally say stop, what is physically different about the patients who fail? Because medicine isn't one size fits all.
Very true.
Who actually benefits the most from this repeat injection, and who is venturing into, like, a danger zone?
To answer that, the sources really point to the role of ultrasound as a predictive tool. There's this fascinating study from 2018 to 2019 that measured something called the linear dorsocaudal movement of the urethra during pelvic floor sonography.
Okay, linear dorsocaudal movement. You're going to have to break that down for me. What are we actually looking at on the screen there?
Fair enough. So dorsal means toward the back, and caudal means toward the tail.
Okay.
So we are literally watching the ultrasound monitor to see exactly how far the urethra gets pushed toward the patient's back and tailbone when they bear down or cough.
Oh, I see.
And they wanted to categorize patients before they ever touched a needle.
Yeah.
So based on this measurement, they split patients into 3 groups. Hypomobile, where the urethra was super rigid and barely moved. Normomobile, showing a healthy, normal range of movement. And hypermobile, where it just swung wildly under pressure.
Okay, and how did those specific movements predict the success of the bulking gels?
Well, the normomobile group, so the patients with a normal range of movement, they experienced the greatest mean improvement in their continence scores after a bulkamid injection.
So the ultrasound proved to be this highly accurate crystal ball, basically.
Exactly. Patients with really rigid urethras or overly loose urethras, they saw some slight improvement, but nowhere near the success of the normomobile group.
Okay, so if the ultrasound shows a normal range of movement, you have a green light. But let's talk about that danger zone. When is a repeat injection actively going to make things worse?
For that, we have to look at a key observational study by Altman and colleagues. They tracked 81 patients who were specifically considered ineligible for mid-urethral slings. These were complex cases with significant comorbidities, mixed incontinence, and crucially, patients who had previously undergone and failed invasive sling surgeries.
Ah, so these are patients whose pelvic anatomy has already been surgically altered in a major way. There's probably existing mesh in there, or at the very least, a significant surgical history in that exact area.
Right. And that surgical history is the deciding factor. In this really complicated group, repeat injections did not improve outcomes at all.
Really?
Yeah, at the 6-month follow-up, symptom scores for patients who only had 1 injection remained largely unchanged. But for the patients who received a second injection at the 2-month mark, their symptom scores actually worsened across all domains.
Wait, getting a second shot made the leaking worse. How does that even happen mechanically?
It comes down to scar tissue.
Ah.
When you've had previous surgeries, like a failed sling, the tissue surrounding the urethra becomes severely scarred and highly rigid. It completely loses its elasticity. So when you inject bulking gel into healthy, spongy tissue, it creates this nice, soft, yielding seal. But if you try to force that same bulking gel into rigid scar tissue, the tissue doesn't yield.
Oh, I see where this is going.
Yeah, instead, the gel creates unnatural hard pressure points that can actually distort the anatomy even further. So it essentially props the urethra open rather than sealing it shut.
Man, that is a massive red flag.
Huge.
If you are trying bulking as a salvage procedure after a failed surgery, pushing for a second top-off might actively harm your pelvic floor mechanics. That is a conversation every patient in that category definitely needs to have with their doctor.
It really underscores why proper patient selection is just everything. Urethral bulking is a fantastic tool, but it cannot override severely compromised, scarred anatomy.
Okay, now speaking of things that seem mechanically counterintuitive, we have to talk about the paradox.
Yes, my favorite part.
This was my absolute favorite piece of data from the entire stack of sources we pulled. It's so weird.
It really is a remarkable finding. It challenges everything we assume about surgical complications.
So this data comes from a single institution study of 29 patients who received macroplastic injections, right?
Correct. The researchers noted a surprisingly high rate of a specific complication, which was transient urinary retention.
Okay.
This is the exact scenario we discussed earlier, where the patient cannot void urine at all. In this specific study, a staggering 48% of the patients experienced this retention post-procedure.
Almost half of them.
Half. They required either intermittent catheterization or an indwelling catheter for an average of 2 to 4 days.
Let me stop you right there. Because if I go in for a quick outpatient procedure just to stop a few leaks, right, and I wake up unable to pee for 4 days,
Yeah.
requiring a catheter, I mean, my immediate layperson assumption is that the doctor completely botched the injection and caused permanent damage.
Right, exactly.
Please tell me the study proved otherwise.
Well, your reaction is exactly how any patient would feel. It feels like a catastrophic failure.
Total disaster.
But the researchers actually followed these patients, tracking their global improvement scores, or GI, for up to 2 years. And that's when the paradox emerged.
What happened?
The subset of patients who suffered that terrifying urinary retention actually reported significantly higher global improvement scores compared to the patients who were able to urinate normally right away.
Wait, seriously?
Seriously, over 57% of the patients in the retention group reported a greater than 75% improvement in their stress incontinence. In the non-retention group, only 40% hit that mark. And this dramatic improvement wasn't just a fluke, it was sustained for over a year.
Okay, so a temporary 4-day nightmare actually translated into the best long-term cure.
Basically.
It's almost like muscle soreness after a really brutal workout. It's this temporary, uncomfortable inconvenience that is actually a biological indicator that the muscle is growing. In this case, the blockage indicates the bulk is working perfectly.
That's a great way to think about it.
But biologically, how does that actually make sense? Why does the swelling lead to a better seal?
So, the authors hypothesized that it's all about the physics of the injection and the body's natural inflammatory response. To get that temporary retention, the doctor likely achieved an incredibly aggressive, evenly distributed periurethral block.
Oh.
The material was injected so perfectly in a 360-degree ring around the urethra that the body's natural immune response, the temporary inflammation and swelling, caused the tissues to swell inward and physically touch in the middle.
Ah, so the swelling acts as this temporary roadblock.
Exactly. The swelling completely blocks the flow for a few days, but once that temporary inflammation naturally subsides, the perfect 360-degree ring of bulking material remains. It leaves behind this near-perfect, highly durable seal.
That perfectly illustrates the razor-thin margin doctors are working with. You want to tighten the urethra just enough to stop the leaks, but not permanently block the flow. And apparently crossing that line for just a handful of days actually yields the ultimate long-term result.
And this completely changes the post-procedure counseling, right?
Oh, so?
Well, if a patient experiences transient retention, a doctor can point to this data and say, look, I know this is scary and uncomfortable right now, but statistically, this means your anatomy is responding robustly, and you are in the group most likely to see the absolute best long-term outcome.
So let's bring this all back to you, the listener. We started this deep dive with a scenario of real frustration. The feeling that your medical fix didn't quite take.
Yeah, that sinking feeling.
Right. So if you or someone you know is navigating stress urinary incontinence, and a first bulking injection didn't perfectly stop the leaks, the absolute most important takeaway from all this data is this: do not panic.
Exactly. The need for a second injection is not a sign of failure, nor does it mean your body is rejecting the treatment somehow. It is a sign of a careful, conservative medical strategy designed to keep you safe.
The data unequivocally shows that top-off repeat injections are common, They are frequently necessary, and they are statistically linked to better long-term outcomes. The weather stripping might just need that one final tailored layer.
Right.
Of course, that comes with the vital caveat that you don't have underlying complications or scar tissue from previous sling surgeries.
Right. Definitely keep that in mind.
And remember, if you don't see results after 2 rounds, it is time to pivot to other therapies. But round 2 itself, it is a standard, highly successful part of the playbook.
And when you understand this two-step reality, it just takes all the fear and uncertainty out of that follow-up appointment. You can walk in knowing exactly where you stand in the process.
Absolutely. But before we wrap up this deep dive, we always like to leave you with a provocative thought. And we pulled something from the bleeding edge of the source citations that is just truly mind-expanding.
It really is sci-fi stuff.
Yeah, because everything we've discussed today relies on static, passive materials, right? Silicone elastomers, polyacrylamide hydrogels. The doctor injects them, they sit there, they take up space, and they don't do anything else.
But the latest biomaterial research, and we're talking specifically about a study cited from 2023, is moving far beyond passive gels. They are actively exploring liquid crystal elastomer-based dynamic devices.
A dynamic device. I mean, we aren't talking about tiny robots, right? We are
Right.
talking about smart materials.
Right.
What if, in the near future, we don't inject a passive gel, but rather a material that physically reacts to your body in real time?
The science here is just fascinating. These liquid crystal elastomers can be engineered to respond to specific stimuli. So imagine a bulking material that sits perfectly soft and relaxed while you go about your normal day.
Okay.
But the microsecond your abdominal pressure spikes, because you cough or laugh or sneeze, the material literally reacts to that pressure or to the surrounding body heat, dynamically changing its shape to tighten and seal the urethra.
That is wild. So it would act exactly like the native muscle valve you lost in the first place.
Exactly.
It's essentially the ultimate reactive weather stripping. It senses the wind, and it pushes back to seal the door all on its own.
It represents a massive, massive leap from providing passive structural support to creating active, reactive prosthetics at a microscopic level. It raises incredible possibilities for how we integrate biomaterials with human tissue in the coming decades.
It's a wild thought to leave you with, for sure. Well, we want to thank you for joining us on this deep dive. Hopefully, the next time you're faced with a medical fix that doesn't seem perfectly binary right out of the gate, you'll remember that sometimes the best tailoring takes more than one fitting. Take care and keep asking questions.